So today let's talk about identifying COPD. My name is Elizabeth Locker, and we're going to be going through the diagnosis of COPD and some of the main factors or causes. So for this first slide, I just put in here a little joke. Why did the lung go to therapy? It was feeling deflated. So I figured Mallory would appreciate that. So yeah, we're just gonna start off by talking about how to identify COPD and the gold standards of classification for COPD and how those come into play. Okay, so what is COPD? Well, COPD is a chronic obstructive pulmonary disease, or COPD. It's a chronic inflammatory lung disease that is typically characterized by symptoms like shortness of breath, cough, increased sputum production, exacerbations, wheezing. I'm sorry if it looks like I'm not looking directly at the camera. I kind of have to look off to the side to be able to see the slides and to be able to follow along, so that's why. But any of those can be indicators. Often before a patient is diagnosed, they'll kind of identify with that chronic cough, or it's also called smoker's cough. And usually their excuse will be oh, I'm sick all the time, which they might get sick all the time anyway. Or they might say oh, I just have allergies. I have allergies all the time, not fully realizing that that is an indicator of them potentially having COPD. Airway abnormalities cause an obstruction in airflow that affects how a patient gets air out. So when we're looking at obstructive lung diseases, especially with COPD, the issue is that the patient can't get air out. So they don't have any trouble getting air in. It's exhaling, how long it takes them to get air out and how much volume it takes them to get air out is the problem. So COPD accounts for roughly 6 to 8% of all deaths globally. The research that I found mentioned between 2012 and 2015. I think the research that you gave us said 2012, but then another one said 2015, so I just put that in there. But ultimately more than 3 million people died. So that is a pretty large number. At least that's, in my opinion, it's a pretty large number. So COPD can actually be a major cause of death. It is a major cause of death worldwide. And just to think that a lot of people don't really fully know about it, especially COPDers themselves, often don't really fully realize what the symptoms are and why they're feeling those symptoms. Especially in the hospital setting, I feel like I've seen a lot of patients that have a diagnosis of COPD and they're kind of still saying oh yeah, I'm just always short of breath, I don't know what it is, not fully understanding that it is because of their COPD that they're always short of breath. They may still smoke, and they may have other factors like we're gonna talk about here that can exacerbate that COPD. So what are the known causes of COPD? Well, COPD has many factors or many indicators. So we have the long-term exposure to cigarette use. This is where we look at the 30-pack year or however many packs they smoke versus how many years they smoke. And typically, this is not a fact every time. This is just a general thing, but typically if the patient smokes more than 35 to 50 years, there's a 95% chance that they're going to have COPD. So obviously there's some outliers. You know, you see patients that have been smoking since they were 12 years old for the last 60 years, and they're only just starting to get symptoms of COPD, which is really kind of crazy. That's got to be a genetic factor in there. I don't know, but but most of the time, if they say they've been smoking like 35 to 50 years, they're way more likely to have COPD. When I was looking it up, it was saying like between like 85 to 95%, you know, guarantee that they're going to have COPD. And obviously nothing in life is a guarantee, but they're just way more likely to have COPD if they're within that 35 to 50 year mark. So some factors, we have long-term exposure to cigarette use, like we just talked about, genetics, and then also environmental components. So when you think about like airway reactivity, right? If I'm a daily smoker and I'm smoking 2 packs a day, and I also have a cat that I'm kind of allergic to, that is my pet, right? The smoking alone is gonna, you know, cause, after a long-term use, is gonna cause that increased mucus and that chronic cough. And then I also, you know, may have more likelihood of both my small airways and my large airways being affected because of that environmental factor, having that cat that I'm kind of allergic to. So all of these things can kind of like just exacerbate our airway. And when it comes to breathing, you know, there's so many factors that can cause reactivity. So that's just really important to keep in mind. Smoking can also encompass smoke inhalation for other toxic sources like asbestos, air pollution, household factors. So a good example of this is my first semester in clinicals. We had to do an adult case study on a patient that was not on a vent, just a regular adult. He was telling me how, like, yes, he did smoke for a long time. I think he smoked for the last 40 years, he said, and he still occasionally smoked when he was like stressed or trying to like cope with something. But he said that he did a lot of like construction jobs and a lot of like pulling out sorry, I just lost my train of thought. Like a lot of pulling out like when it comes to pulling out drywall. Thank you. I don't know why that just came to me, but a lot of like pulling out drywall and stuff. There was it turned out that the people below the room that he was pulling out all this drywall, they were producing crystal meth. And so for like he said it was like throughout this business, he was pulling out all of this stuff, and it took quite a long time to like redo this whole area. And all along, these people below were apparently producing crystal meth, and the fumes and everything got to him, and he said that was when he started having these exacerbations. And he didn't know at the time that initially what it was until later when the people got busted. He kind of put 2 and 2 together, like, oh, I was above them this, for a long period of time. And that's when he started to have all these symptoms. So it was really kind of interesting because it enabled me to see kind of more of a full picture. Like, okay, yes, smoking is a factor, but also your environment. Like, like I kind of mentioned, like with the cat or, with something like that, there's just so many other factors that can go into it. And sometimes we're not even aware of them. So how is COPD diagnosed? Well, there's 3 main symptoms of COPD that are pretty common to see. One of them, or no, actually 2 of them we already mentioned quite a lot. So we have chronic cough is a big factor, or smoker's cough, and then increased sputum production, but also chronic dyspnea, so chronic shortness of breath can be a big factor. So chronic cough can affect roughly 30 to 40% of COPDers. It can be the first symptom that presents. It usually kind of gets excused by patients, like I mentioned before, of them just being sick or having allergies. And then chronic shortness of breath is a very common symptom that affects most COPDers. And after a while, you know, it's one of those factors that can really cause them a lot of anxiety. Because if you're short of breath all the time, you know, it's gonna worry you, obviously. And then increased sputum production. So often patients may not report coughing anything up unless that connection is made that, okay, this coughing something up could be the result of something else. So some other factors are chronic fatigue, weight changes, like usually weight loss, wheezing, tightness in the chest, or, you know, frequent colds, frequent respiratory infections. Okay, so some key indicators that can help us diagnose COPD. So I want to talk about spirometry. It's often done at bedside, or it can be done in a PFT setting. But spirometry is a test that can often be taken bedside. It is a test that is used to diagnose certain lung conditions by measuring the air that a patient breathes out in a forced breath. So we're talking about COPD and them having trouble get that air out. It's so important to be testing for that, because that can ultimately be an indicator, right, of whether or not they have COPD. So some of the maneuvers taken during this spirometry test are the forced expiratory volume 1 second. So it's just basically just a forced exhale to see how much volume they're exhaling in that 1 second, also known as an FEV1. We have our forced expiratory flow, and then our peak expiratory flow rate, and our forced expiratory flow 25 to 75. So the 200 to the 1200 is the larger airways that it's test for, and then the 25 to 75, I just think of those as the smaller airways that are tested for. And then the peak expiratory flow rate is also something that we see with asthma patients. So it's like that deep breath in and that fast and quick breath out, kind of like you're blowing out a birthday candle. And that also is a good indicator. And then we look at the FEV1 over the FVC ratio. And usually 70% is a good indicator of an obstructive airway disease. So less than 70%. FEV1 and FVC are often the most common looked at values and are the most important determinants. So I just included the classification of airway limitation severity scale. I included on the following page too, just because it is important. It's a main factor. But you have the different levels. So you have gold 1, gold 2, gold 3, gold 4. And this goes back to what I said about wanting to, or having to know those gold standards for the classifications of COPD. So FEV1 greater than or equal to 80% of predicted. So when we're talking about predicted, it's really just the amount that they should be at. That's their predicted amount. And then if it's greater than or equal to that, then it's just mild. Less than or equal to, or less than 50% of the FEV1 or less than 80% is moderate. And then for severe, it's usually between 30, it's like 30 to 50%, like 30% less than the FEV1, and less than 50% of predicted. And then 4, very severe, is going to be less than 30% predicted. So, yeah. So another key indicator of COPD that helps with diagnosis purposes is the post-bronchodilator test. So this is usually done after the spirometry test, and it's to test their airway reversibility. So when I first saw this done, I thought it was pretty cool because when you think about how often we give people breathing treatments, right? Why not test them to see if the breathing treatment is really effective or not, you know? So just like the slide says, post-bronchodilator is often tested following spirometry test, and it's used to test the airway reversibility of the patient to get an accurate indicator of how effective a bronchodilator will be. So something that I know Mallory has always drilled into us, our program director, is that an increase of 12% or 200 milliliters, then the obstructive disease will be reversible with a bronchodilator. Less than that, and it's considered ineffective. Obviously, sometimes it's just a peace of mind thing, right? Like, if a patient is always short of breath and they get a breathing treatment, to them, even though it might not help or really cause reversibility factors, it also might just be peace of mind that, okay, this is doing something. I'm doing something to help myself feel better, you know? So that's also a factor too. So these tests are mandatory to determine the diagnosis of COPD, but then also environmental factors, kind of like we already talked about, patient's history, all of those things also come into play when it comes to identifying and diagnosing COPD.